Welcome today to Let's Talk Parkinson's, where the topic is the role of speech pathology in protecting and maintaining communication and swallowing. We have speech pathologist Zia Gallagher-Beverley with us today from Network Speech Pathology. Zia is a senior speech pathologist and has extensive experience supporting people living with Parkinson's across all stages of the condition, with a focus on communication, voice, swallowing, and maintaining quality of life. So welcome today, Zia. Thank you so much for joining us. And over to you whenever you're ready.
Thank you. Good morning, everybody. I just want to say thank you for having me. It's an absolute privilege to be a part of this. I'm just going to share my screen. We'll go through some slides. Stacey has also spoken with me about the questions that you sent through already. So I believe most of those questions should be answered in the session today, but anything that hasn't been answered, please do say them again and we can go through them individually. So basically the whole goal of a speech pathologist in Parkinson's disease or treating somebody with Parkinson's disease is to support informed care. My goal as a speech pathologist is to have you at the center of the care and to make sure that you have as much information about the progression, the symptom management, the team around you, and the critical needs that you yourself as the person with Parkinson's have, as well as those around you, your family, your immediate spouses, anybody else that's in your orbit, and then coordinating with the GPs, with your physios, whoever else is on your allied health team. My background is in hospitals. I worked in hospitals for 7 years working with people with Parkinson's in that acute, subacute, and chronic stage. And then since working with Bree, I'm seeing more of that early diagnosis as well as that later stage chronic acute to chronic. So there may be some questions that I might not know as well as Bree. And if that's the case, what we'll do is we'll park it there. I'll ask Bree and then we'll come back together. Right, now can you all see that moving through? Yep, cool. Oh, and I speak a lot more than slides. So if I repeat it again, I'll mix through it. I'll go through it a little bit. I'm not a slide person, I'm off the cuff. So who's our team? This is Network Speech Pathology. We're all experienced speech pathologists. We all have different passions, but the main focus is about supporting communication and swallowing difficulties in acquired conditions. We work with adults Australia-wide, predominantly via telehealth. So telehealth is exactly what you see now via a screen. And then if we do have concerns, we can see, depending on location, we can see our clients in person. It's just location specific. We're all trained in the Parkinson's Voice Project Speak Out program. I'll speak about the 2 gold standard therapy programs later on, but just know that we're all trained in that one. And moving on to the next slide here. So one thing that I would like everybody to keep in the forefront in their mind is that we know that Parkinson's is degenerative. We know that it changes over time. We also know that everybody's journey is different. So what may be the case for somebody now might never be the case for somebody in the future. What might be the case currently can improve with support or can deteriorate irrespective of that support. It can happen unexpectedly or it can happen slowly. So the most important part of the speech pathologist on your team is to try to be ahead of the game. So we talk about not so much obviously remediating the issues as they come up, but also protecting what we have now and then trying to improve on what we have now to keep that protected in the future as well. And if that doesn't make sense, I'm talking about Communication, swallowing, engagement as well is a big one. So we know that social engagement is lower in people with Parkinson's who are suffering from swallowing or communication difficulties, purely as a result of embarrassment and shame. So what I would like to do as a speech pathologist is to empower all of my clients to, one, reach out for support, and two, reconnect with their networks, feel confident in their environment, feel confident with the plan if something does happen, say if it's a choking episode or difficulty swallowing. Let's have strategies in place to support you in the future. So in my mind, it's not just about treating those problems, it's staying one step ahead, and it's about forecasting what might happen in the future as well. So forgive me if I say some things that you've already spoken about with your neurologist or your clinical nurse consultant, but Parkinson's disease occurs from a loss of dopamine. And in terms of movement, there's two motor systems at play. So we have the automatic motor system, and then we have the intentional motor system. So can you see my cursor, Stacey? Yeah. So when we have movement patterns, they start here. The thought or the actualization of the pattern starts here. And you can see through this that there are so many stops along the way. Here, there, there, there to there, there to there. Can we see that there's quite a lot involved? Until we get to here. So this is that substantia nigra, and that is where the majority of dopamine lives. And what we know about people with Parkinson's is by the time that you are diagnosed with Parkinson's disease or suspected to be diagnosed with Parkinson's, you will have lost 60% of your dopamine. So that means that these little signals that are trying to get to the substantia nigra, by the time they get there, they don't have enough dopamine to keep going. So we call this the back road. You're driving along a back road, you're taking 5 million different turns to get to the one spot. A nightmare for somebody with Parkinson's because we know that movement patterns are affected by the loss of dopamine. So have I missed anything in the slide because I'm speaking without the slide? Yes, so this motor system is all about automatic movement. Those automatic movements, for example, people with Parkinson's, is talking, swallowing, walking, swinging our arms when we talk, all of this hand movement that I do when I'm speaking, it's all automatic. I wish I could stop it, I can't. And we perform these actions without conscious effort. So it's highly dependent on dopamine. Now I'm going to give you an alternative. So the second system is the pyramidal system, which is the intentional system. And where you can see before we had a million back rows, we've got cell firing here, intention here, and it goes all the way down. One, we call this the highway. I don't want to go on the back road, I want to go on the highway. Takes you through to the substantia nigra. And we haven't had a million stops along the way. So where we were fatiguing here, because we had so many stops, here we're actually bypassing that substantia nigra. We don't need it here. So this is where we use those intentional, deliberate, forceful movement patterns. So that's where if you're learning to ride a bike, when you're learning to ride a bike, it's really effortful. You might have your tongue between your teeth because you're thinking so hard. And then eventually riding that bike becomes automatic. What we want to do is we want your life to become intentional, to bypass those back roads and to get on the highway. Is that new information? That intentional motor system is like a little feather in our cap. It's the biggest weapon we have against managing the symptoms of Parkinson's disease, because the intentional system is not dependent on dopamine, and therefore the lack of dopamine is no longer impacting those moods. Okay. So that intent will have a significant impact on your life. Ignore the typo. So then, as I said earlier, everybody's symptoms will be different. Everybody's disease progression will be different. Somebody's symptoms now will be different in the future and will be different to the person sitting next to you, or as I say, on the screen next to you. But because we know that Parkinson's disease impacts the ability to speak and swallow, when a speech therapist uses intent to bypass the automatic system, what we're doing is we're activating that intentional motor system. And it's similar to if you do physio sessions. You might notice that your physio is getting you to do really specific movement patterns. They might talk about big patterns. And all of that is new. So we know that that's also activating that intentional motor system. So I'm going to move on from that one. If you have any questions about that motor system, please write them down, and I can answer them at the end of the session. And hopefully anything that's really flagging for you potentially will be answered as I go along. And if you haven't had a drink as your speech pathologist, please have a little sip. Okay, so there are two primary domains that speech pathologists support people with Parkinson's with. Domain number one is communication. And communication is not just what you might think being voice changes or some fascinating speech, almost sounding a little bit like a stutter, which we would call articulation. And also not necessarily just breathing related changes to speaking. But it's also the pragmatic component of communication. So because we know that Parkinson's and the loss of dopamine reduces the largeness of movement, so that we have smaller movement patterns. That smaller movement pattern will also impact on our facial features. The wideness of our smile, the shock we might show, it all starts to reduce as Parkinson's goes on. So when you're having a to and fro communication, we're not just watching people's mouths. We're watching for eyebrow movement, me moving my hands around. All of the rest of that comes into that pragmatic or that social language. And in my experience with people with Parkinson's, that can be something that's really hard to mitigate. And what I often do is we talk about supporting with advocacy. So first off, empowering you with the knowledge that those changes are related to Parkinson's disease. And then also potentially having somebody on your team who says, you know, Patricia has reduced facial movement as a result of Parkinson's disease. And that can just be a little bit of extra knowledge that that person who's sitting across from you who doesn't have the same knowledge of Parkinson's that I do, or Stacey does, or your carers do, to help you engage better in communication and to make you feel more confident that the people around you can support you. And then there's also the use of alternative communication devices such as voice amplifiers. And that's an area that I'm still learning about myself, because my background in a hospital setting was more the initial critical assessment planning, and then the clinicians in the outpatient department with support with the voice amplifier. So that's something that I'm really excited about learning about. But I might not have as much knowledge as Bree would in terms of education. So let's just see if that comes up as a question and ask Bree. The next area, the second area, is swallowing difficulty. Now, Stacey has shared some of those questions, and they do indicate that a few of you are already starting to experience some swallowing difficulty. So examples of this, for those that haven't, is not sure what that means. Areas of support. So we can, I'm not sure what that is. Ignore that first bit. The second bit is about tablets. So people can have trouble swallowing their tablets. That's usually the first reported symptoms that a lot of those early onset Parkinson's, or if you're in the early stages of Parkinson's disease, that's often what they'll say. I'm having trouble swallowing the tablet. What can I do? I'm going to get there. I've got a slide on it. And there are some really great, easy options that we can do starting strategies for you as well. We want to help with mealtime ease and experience. So again, it goes back to knowledge being power. If you know the limitations of your swallow, if you have great strategies in place, it will continue to allow ongoing access to a variety of oral intake. Social eating, we know how important social eating is in terms of being a part of your family. All of our social gatherings are often surrounded by food, thinking about Christmas or Hanukkah, all of those celebrations have food. So social eating is critical. It's not just about your safety, it's also about your enjoyment as a human being living with Parkinson's disease. We might modify food and fluid. I'll talk more on that later. And we might provide some environmental strategies as well. So we're going to move to the start of the communication with dysarthria. So I alluded to that earlier. Dysarthria is a motor speech impairment, and it usually affects the areas of voice, articulation, so that's the movement. So voice comes from here, that's where the vocal cords vibrate. Articulation is the tongue, the teeth, the back of the throat, the nose, all of the coordination of those movement patterns to create sound or to shape sound. So sound is created here, we shape it here. And then respiration is critical for voice because without breath, we have no voice. We speak on the out breath. Something that I find really interesting is the people without Parkinson's, but those with Parkinson's too, will take in the breath that they need for the words that they're going to speak. I'll say that again. We take in the breath that we need for the words that we are going to speak. And because we speak on the out breath, if we have any disorder of respiration, our out breath will be less and our words will trail off. Does that make sense? Yeah. So the most common type of dysarthria that we see in Parkinson's disease is hypokinetic dysarthria. What that does, going back to the dopamine content, it affects the way that those neural messages are sent and received. So we don't just send the messages, but we also receive the messages via that motor pathway. And then what that does is create changes in the size. It affects the size of those movements, so the largeness of those movements. It affects the speed, and it affects the coordination. And then as a result of that change in the size, we have a weakness or a reduction in strength. So it's not that Parkinson's makes your muscles weak. It's that Parkinson's reduces the range of movement. And then that reduction in range of movement affects over time how much those muscles can fire. Does that make sense? So if I'm only ever walking in short steps eventually my muscles weaken enough that it can only get to those short steps. But it's not that Parkinson's makes you weak. It's that the movement is less because of that dopamine issue that we had earlier on. But if we work on intent, we can then widen the range of movement, which therefore strengthens those muscles. I hope that difference makes sense there. This one is, look, I always make people laugh, particularly the family members of people with Parkinson's disease, but people living with Parkinson's disease. I'm sorry for saying it like that. My brain just goes ahead of me. You're living with Parkinson's disease. You're a person with Parkinson's disease. They're interchangeable for me, and I'm sorry if I say it in a way that is not respecting the terminology. So please forgive me for that one. But a lot of the men who come in to me with Parkinson's disease say, everybody around me is deaf. They're all deaf. They can't hear me anymore, but it's their fault. They're deaf. This is because of that auditory feedback loop. So if I walk into a room and it's really loud, I'm going to increase my volume without thinking to compensate for that loud. Equally so, if I'm in a quiet room, I'm going to reduce my volume to an appropriate volume so the person across from me doesn't think I'm screaming at them. And that's that auditory feedback loop. And with people with Parkinson's disease, that feedback loop is impaired, which is why they feel as though everybody around them has suddenly turned deaf, become deaf. It's not because you're not hearing, and it's not because you have a lack of effort or because you don't care. It's because sorry, I'm just making sure I said it correctly. Yes. The loss of dopamine in that basal ganglia is affecting your perception of speech, affecting that feedback loop, and then therefore affecting that movement pattern that you're trying to execute. So one of the goals of speech therapy is to recalibrate that internal perception. And it can be really hard in those early stages where you feel as though you're screaming. And what my job as your speech pathologist to do is to say, no, you're not. We often record you so that you can hear the difference in what you think is screaming and what is actually appropriate speech decibel level. Going back to that movement pattern we spoke about before. So it's not just movement isolated to speech and voice. It's also movement of the chest, your legs. All of that is a part of Parkinson's disease and its impact on your body. So if I'm speaking like this, I'm reducing the amount of communication that I can do because I'm naturally affecting the range of movement. So positional changes can be so important, and that intention creates that wide chest, that large volume, and I can project my voice over you. Whereas if I'm like this, the limitation is so big. So that's a good example of when we have that reduced effort, that reduced movement, the poor vocal quality, the posture impacting, that respiration, the reduction in facial movements, that all creates this downward communication path. Whereas when we open up, when we use intent, it all improves. So that's the end of communication there. If you have any questions, write them down. If there's anything I haven't answered, write it down, and I can answer it at the end. We're moving on to swallowing problems or dysphagia. You can see there that it's dysphagia. And this is something that what from my understanding is quite paramount for a lot of you here today. So I hope that these questions, this presentation supports you. But it's a large area that I have experience with, but unfortunately, it's an area that can impact your life. So why does it occur? When we spoke about that slowness, the smallness of those movements, the reduction of the size of those movements, they create a change in the movement pattern, which can make that area weak. Not weak because of Parkinson's, it's weak because of the movement. And that could also affect coordination of the muscles. So interestingly, the reason dysphagia and swallowing issues are a part of the speech pathologist domain is because they're the same muscles that are involved in communication. So we have 52 muscle pairs that are involved in swallowing. And again, it's an automatic movement pattern. In this time, I suspect many of you have swallowed your saliva. I certainly have. I hope you've been drinking. All of that is an automatic movement pattern. And when we have swallowing issues, it can affect food, fluids, and tablets, but it also can affect keeping saliva in your mouth as well. Swallowing problems are very common in neurological conditions, as well as in healthy age. So we know that any change in muscle movement, which happens with age, can affect the swallow as well. So it's not just specific to Parkinson's disease. It does occur alongside healthy aging and other neurological conditions and a multitude of other conditions that I don't go into. Speech pathologists separate the swallow into a number of phases. I'm only going to speak about 2 of them now. But we have the oral phase. So that is everything from here up. Can you see my cursor there? So you can see somebody here has spoon, they're bringing it to that person's mouth. These are the lips. This is that palate that separates the nose or the nasal passage from the oral passage. This is your tongue. The tongue is huge in your mouth. And then this is the base of your tongue. This is the velum, so that's the dangly bit at the back that you can see, the uvula, and that closes up. So when we say it sounds like or when we're drinking and eating, this moves backwards and blocks off the nose. So that's how we don't have food and drink coming out of our nose when we take it in. The food is manipulated by the lips, the tongue, the palate, the tongue touching the palate, the uvula moving back and the velum moving back. All of that is coordinated automatically in swallowing. And it's different for different textures. So we would have a different movement pattern for, say, custard compared to a really tough steak. I'm sure you can all attest to having to chew multiple times for a steak compared to custard. But as the steak is entering your mouth, you're not thinking, I've really got to chew a lot here. It's an automatic process until it's not. And that's where I like to describe swallowing issues as a muscle that you didn't know you had that hurt at the gym when you used it for the first time. All of a sudden, it becomes really obvious, and all of a sudden, you start to need help, and that's a weakness. So that's the oral phase. And we'll move on to the pharyngeal phase. So that's that throat area. And Stacey, can you see my cursor again? Yeah. Okay, so here we have the back of the tongue. So basically, as soon as food hits the back of that tongue, it starts to coordinate the pharyngeal phase. So as it hits here, the tongue moves back to the posterior pharyngeal wall, which is here, and the food is then squeezed down. Now, this is your airway. Can we all see my cursor? And this is your esophagus. We don't want any food in your airway or drink, and we want it to go into your esophagus. And this here, the epiglottis, is the first line of defense for the airway. So as the tongue moves backwards, this creates an upwards trajectory of your throat, which in turn pushes the epiglottis down or back. That protects the airway. The first line of defense. The second line of defense is your vocal cords. They're about here, if I were to have this imaginary person in front of me. And what they do is they slam together. That's your second line of defense. And this is the reason why if food or drink enters into that airway, we cough. Because that is the body's tool to get things out of your airway. So when people say to me, I'm coughing, I'm actually thinking, great, you're coughing. That's wonderful. Your body is doing what it needs to do. I need to work out why you're coughing, and I need to support you in terms of potentially making some changes. But I'm really glad that you're coughing because that is protective. Everyone's afraid of the cough. The cough is just data. The cough tells me I need to look more. So as the food comes here, epiglottis closes down. This opens this passage more. And then we have a sphincter here called the upper esophageal sphincter. That opens like that and lets food in. And that food enters your esophagus and travels down to your stomach. That's how a swallow works. Swallowing issues can occur, I might just go back quickly, at any stage. So you could have swallowing issues in that oral phase, particularly if you don't have a lot of teeth. It might be coordination of that tongue, might be really tricky. It could be that the food is too much for the receptors along here to control, and so it might spill out. Spilling out can also be because of lip pressure. So we talk about the swallow as a series of pumps and valves. So we have a valve and a pump. So that's a valve, closing down. Another valve is here. We could have, and because they work in synchrony, we could have an issue with the epiglottis here not closing because food has slipped over the back of the tongue before the body was ready to swallow. And then therefore, we haven't swallowed, so that airway is open, and then the food can enter. So it's not just one or the other, it's usually what came first and why. And that's where my job as a speech pathologist is to put the pieces of the puzzle together. So health risks, and am I talking really, really slow? We're okay? Right, health risks, the biggest one is aspiration pneumonia. I'm not sure if anybody has come across that term yet. I'm not sure if you've been hospitalized for an aspiration pneumonia. If you have, I'm sorry. If you have, we would love to support you. Aspiration pneumonia is exactly what it is, exactly what it sounds like. So a pneumonia is a chest infection. If we go back to that slide, when food and fluids enter the airway, sometimes they are cleared out, sometimes they're not. Sometimes they travel down into the lung. If it travels down into the lung, what the body does is it creates a chest infection to try to clear it up and out. The reason it's called aspiration pneumonia is because the terminology for food entering the lung is aspiration. So it's pneumonia as a result of food and drink entering the lung. But it's not just food and drink, it's also your saliva. So if you have a swallowing problem with food and drink, you very likely have a swallowing problem with saliva as well. So there are strategies that we can use to support people who are having aspiration pneumonia. And also, you can aspirate and not develop a pneumonia. If I might explain that a little bit later, but actually, no, I'll explain it now. And it all comes down to oral health. So if we have a really clean mouth, And there's research done on this. If you have a really clean mouth and you drink water and it goes the wrong way, you will not develop an pneumonia. Equally so, if you drink water and you have a lot of bacteria in your mouth, you haven't cleaned your mouth, which is very common for people who have Parkinson's disease in those later stages and they need support with cleaning their mouth. That is when you're going to get an aspiration pneumonia, because that bacteria that is in your mouth will follow with the fluid into your lungs. So it's not just saying, I have a swallowing problem, I'm destined to get aspiration pneumonia. No. You might have a swallowing problem. We will support you with modifying your environment, your diet, empowering you to have knowledge around it, which includes vigorously cleaning your mouth, which therefore reduces that risk of aspiration. So it's not all, I'm hoping to create a situation where I'm not frightening all of you that if you're having swallowing problems, it means you'll get this. It means that there's a lot of things we can do to support you. The next one is choking. Choking is different to aspiration. So choking is when this airway up here is blocked, partially or fully. So that your airway, for human beings, for men it's slightly larger than females, but it's about the size of your thumbnail. I don't know if you can see my thumbnail there. A woman's is probably, well, it's 1.5 centimeters to 1.8 centimeters. So a male's is about 1.8 centimeters and a woman's is about 1.5 centimeters. So thinking that's quite small. So if we have 1.5 centimeters and it's partially blocked, half of the nail is covered, that would be a partial obstruction, which means that only that small amount of air can get in. If it's fully blocked, we would have a total obstruction. So that's a choking episode. Aspiration episode is when little bits of food and drink sneak in, essentially. They don't block the airway, but they sneak in. And that would be where we would see that coughing, that frequent coughing. A choking is more turning blue, gasping, holding your throat. It's a medical emergency. Whereas those repeated aspiration episodes are more those little coughs or throat clears that we see throughout the day. Another one is discomfort. So this is a symptom or a health risk for aspiration, for choking. Get your brain on. The swallowing, discomfort with intake, unintentional weight loss, dehydration. That's a really big one. Nutritional deficiencies, tablet, food, or fluid avoided. I spoke earlier about that decline in social engagement, so that reduced participation in your daily life is a huge health risk for multiple areas of people living with Parkinson's disease. And it also really impacts well-being and quality of life. Now, I've probably said a lot of this, but I'll just go over them again because it's important to know those red flags. So the first one is difficulty managing your saliva or constant phlegm. Difficulty biting down food. Prolonged, so slow, effortful chewing. Food or drink falling out of your mouth. A lot of food left in your mouth after you swallow. So you might take 4 or 5 swallows to clear what is in your mouth, which then goes to multiple swallows per mouthful. Throat clearing or coughing during or after a swallow. A choking episode, like I spoke earlier about that, going red or going blue, holding your throat. You might, usually a medical emergency, so in my experience, it's often resulted in an ambulance call out. It could also be multiple chest infections, multiple hospital admissions for these aspiration pneumonias that are being managed in hospital, but you return shortly thereafter. And hopefully you would have seen a speech pathologist in that hospital. A wet or gurgly quality after eating, temperature changes, fatigue during meals is a big one. And what we see with that fatigue is that as time goes by, you eat less, and then you have weight loss as a result of eating less. So it becomes an avoidance pattern. I've also experienced with people where a large meal is put in front of them, and just seeing the size of the meal is like a mountain that you can't climb. But if we broke that meal down into smaller bits, so you had a quarter of it, and then if you're still hungry, you can have more. That can be a helpful way to strategize that overwhelming fatigue that is often something you know is going to happen. Another one, so I spoke about aspiration being and how important that cough was, how I'm happy that you're coughing, how I'm almost ecstatic that you're coughing because it's a symptom that I want you to have. And another type of aspiration is silence. So that's where you're not coughing. You're not showing any of these red flags for swallowing issues, or at least you're not showing any of those overt coughing, choking episodes, but you're having multiple chest infections, and that is silent aspiration. It doesn't happen as much in Parkinson's disease with people for people with Parkinson's disease, but in my career, I've treated a lot of people with silent aspiration. And it's really tricky to manage at home because you don't have any of those symptoms that you're experiencing it. But that is where it would come up under rigorous investigation by myself and usually a speech pathologist doing an X-ray swallow, because the only way we can see silent aspiration is under X-ray. I might just quickly see. I just want to talk to that first. So sorry, just forgive me from jumping around. Just trying to work out how to do it. So I'm going to say it now. When we assess somebody's swallow as a speech pathologist, there's two ways that we can assess the swallow. The first way is to assess in front of you. So you're sitting next to me or on the screen. I would ask you to eat a variety of food. All foods that I know will be increasingly harder and increasingly effortful for somebody with Parkinson's disease. So I usually will ask you what you're eating first. And if what you're currently eating is the highest level, then I want to see that. If you're already avoiding food, so you're already avoiding tough meat, or you're already avoiding drinks, I really want to see as much as I can. So that's a bedside swallow assessment or a clinical swallow exam. So that's me in front of you, watching what you're doing. I might touch if I'm in front of you, but the evidence now is showing that you can still get equally robust information without physically touching. I just need to see. I need to see this part up. And then from there, if I'm concerned and if I'm not getting enough of a picture that my clinical exam could give, so we know that that's over 75% accurate. And the reason it's only 75% accurate is because I don't have X-ray vision sitting here in front of you right now. And if I'm concerned about that 25%, which usually, as a senior speech pathologist, and any speech pathologist really, who's had experience in swallowing, should be able to make clinical judgment based on evidence-based, anecdotal previous experience, and what we're seeing in front of us. If I'm concerned, that would be when I would ask for an X-ray swallow. So this is when you would go into a hospital or an X-ray clinic. You eat those same foods, but those foods have a barium contrast added so that we can see exactly where it's going from start to finish. So we can see if it's going the wrong way and you're not coughing. We can see if it's getting stuck up here and why. And that's where we might use strategies like swallowing exercises specifically to PUD. But we don't often use a swallowing exercise until we have evidence of its value under X-ray. So I'm sure there's going to be a slide on that later, but I just wanted to explain that in relation to silent aspiration. So if we are concerned, we will look under X-ray and we will confirm our concern under X-ray. I hope that makes sense. Some simple strategies right now, without having had a speech pathology assessment, is to really focus on your positioning. So being upright is critical. Not sitting in a recliner, eating dinner in front of the TV, if you can avoid it, because level of alertness and position are really critical. I wouldn't drink a glass of water laying in bed, and I don't have Parkinson's disease, because the mechanism of the swallow is that we need gravity on our side. So if we're slumped in any kind of awkward position, we need to position as best as we can upright, and we need to be as alert as we can be. If fatigue is an element and we're finding that we're really tired by the end of the day, I would ask you to consider having a softer meal at that point, so that you're not adding such a load on your swallow in a time when you know you're tired. We also know that with Parkinson's disease, when you're on levodopa, we have those off periods or those weaning periods. So the medication only works for a certain period of time. So when you're on your on time, when the medication is working, that's when we want you to be swallowing. If you're, say, having it at 8 and then you're not having it again until 12, I would be talking with your neurologist and saying, how can we change this medication plan so that this person can have their swallow supported for lunch, dinner, and breakfast? So that's something that we would consider as well, is medication time and their impact on the swallow. Slowing your pace, so not rushing through a meal, having a break after each mouthful. Remaining seated upright after that meal too can be helpful as well. And then critically is keeping your mouth really clean and ensuring that you're hydrated. So I spoke about positioning earlier. We don't want to be to the side. We don't want to be reclined. Ideally, you want to have your legs or your feet touching the ground. Feet flat against the floor, or if you're in a wheelchair, on that foot plate or footstool, just so that you can get that bearing down movement. Yes, I've covered that. Okay, so I've spoken about oral health earlier, so I don't need to go too far into it, but basically the most important part of any of this, if you have swallowing issues or if you don't have swallowing issues, is to start cleaning your mouth as much as you can. If you have swallowing issues, you have great oral health, and you have a functional supported immune system, you have no risk of developing aspiration and raising. If you have dysphagia, if you have poor oral health, and you have a good immune system, you have a lower risk. If you have dysphagia, you have good oral health, but you have a compromised immune system, you have a medium risk. And if you have all three, you have high risk. So those are those three pillars of aspiration that we talk about. And Stacey, I can send you another infographic on the three pillars that you could share with everybody later on as well. But if there's one thing I want you to take from today, is that your oral care is critical now, not in 10 years, not in 5 years, not in 2 years, now. So swallowing tablets. Again, I said earlier on that it's something that everybody experiences quite often. And when it happens, it's hard because you need those medications. A lot of people say to me, I'm crushing them. And pharmacists would lose their mind if they heard that, because look, some medications cannot be crushed. So we don't want you to crush them as the first step. Instead, I want you to try to use these strategies. So do one at a time. Don't have 5 in a handful. I know it seems counterintuitive because it's prolonging it, but definitely don't have 5. Have one at a time. You can use a medication gel such as Flute, so it's an oral lubricant. It's similar to if you were to use yogurt or custard, but some medications really interact with that with food, and some medications you can't have with food. So that's where this oral lubricant Flute can be really helpful. You can get it from most pharmacists. And if you can't buy it in your chemist pharmacy, ask them, and usually they can get it in. The other option is a pill cutter, if that tablet can be cut. So some of them can't be cut because they're slow release, so they have an enteric coating that cannot be impacted in any way. Very quickly, sorry, I talk too much. I'm just really passionate about Parkinson's disease and supporting people with Parkinson's disease. So I'm sorry if we're eating into time. So another thing we might do is modify diet. And this is something that I really try not to do for as long as possible. So speech pathologists, we separate food and fluids into different categories, and we also categorize them based on level of consistency. So a regular diet would be something like steak. Easy to chew includes bread. Soft and bite-sized is really cut up food. Minced and moist is mashed. So basically it's mimicking what the body would do when we've chewed it up and we're just about to swallow. Is that minced and moist? Pureed is as you expect, pureed, and liquidized is like. And then we have different levels of fluid. And you might hear a speech pathologist modifying it. Again, this is something that I really don't like to do until it's absolutely necessary. And often I would prefer to have it confirmed under X-ray done. This is where a thickener would be used, similar to if you're making a gravy and add cornstarch to thicken that gravy. There's thickener recipes that are used to thicken fluids, and there's different levels. So there's slightly thick, mildly thick, moderately thick, and extremely thick. That is a very quick snapshot, but it's something that would be discussed in detail with you as a speech pathologist. Okay, spoken about assessment. So what we would do, we ask questions, we take a thorough case history. If we're concerned about communication, we do oromotor tasks. So we want to see how those movements are functioning. We ask how your oral health is. We assess your communication. We assess your swallowing, and then we create a specific goal and strategy for you going forward. There's 2 gold standard communication therapies, LSBT loud and speak out. We're all trained in speak out. I was trained in LSBT and I worked in that space for a very long time, so I know the difference between the 2. They're both evidence-based, they're both gold standard, and they have a very specific series of exercises that you do daily to communicate, to strengthen that communication. But the whole concept of that therapy is that it is a daily function daily practice that you have to do. It will not work if you do it once a week. You have to do it. You don't necessarily have to do it with a speech pathologist daily, but you certainly have to do it yourself daily. There are some respiratory exercises that we can do. So this is a respiratory muscle strength training device. That is specific, so we would need to assess its function, and we would need to know that respiration is a critical necessity in your case. And swallowing exercises, so I spoke about them earlier. There's low evidence for using them unless they've been confirmed under X-ray, and in that case, then we would have a protocol in place for you to do it. Okay. Yeah, so as I said earlier, we want to be on your team early. Don't wait until you have symptoms. Get that assessment earlier on so that we can get a baseline. We can have a plan in place. You have somebody, if swallowing does deteriorate, you can learn those communication exercises earlier, you can practice earlier, and we can improve your participation earlier on. And so close, Stacey. If you need a speech pathologist and you can't find one in your community, or you have enjoyed the session today with me, we offer telehealth sessions. So we're nationwide. If you have any questions, you can reach out via that email address, or you can call on that phone number. And so yeah, any questions, please go there. And we're here as a speech pathologist. We care. We get into this profession because we care so much, and we want to be on your team.